Take one. All right. Well, good evening, everybody. My name is Jeff Clean. I'm the Executive Director of the SIU Alumni Association in Carbondale. And I should also say to our Carbondale alums, happy homecoming. So it's my pleasure to welcome everybody back to the Carbondale campus. And this is one of the first times that we meaning the School of Medicine and the Carbondale Alumni Association, have ever done a joint reception before. So I've been talking to the dean, I've talked to Cassie. We're looking at making more of these type of activities possible for each of our respective alumni groups in Carbondale, Springfield, and perhaps maybe even around the state. Maybe even think about taking it on the road. So we'll see how this all goes. But it's my pleasure to welcome everybody here this evening. I do want to say a special thank you to Cassie Matson from the School of Medicine and Kathy Maldasius for making this event possible tonight. And I know we're not on a time crunch, but I want to be cognizant of everyone's time here in person, to our folks here on virtually. I want to get right to the program. So it's my pleasure to introduce Jerry Cruz, the Dean of the School of Medicine, who is going to introduce tonight's speaker. So, Dean Cruz.
Okay. Yeah. Jeff, thanks so much. I'll echo your thoughts. We look forward to doing more collaborative things with SIU Carbondale. The School of Medicine was founded in 1970. We're 52 years old now. We've really done some great things, but we've certainly matured over that period of time. Actually, on your tables is a little a two-pager that gives a good snapshot of what the School of Medicine is right now. And I'll just mention a couple of things. We have grown considerably over the past 10 years. We now have 3,100 people total in all of our various categories. So 2,200 in Springfield, 500 in Carbondale, including faculty, staff, and learners, and then 400 in other places throughout the state. We now are approaching 1,100 learners, so 320 medical students, 417 resident physicians and fellows, about 150 physician assistant students, 80 graduate students with the new umbrella graduate program, and about 60 med prep students. So, all across the board there. One mention of some things that are happening in the School of Medicine. Recently, the School of Medicine was awarded the Stellar Award, which is the major lifetime achievement award of the largest medical education group in the world, the Association of Medical Education of Europe. And we got that, there were only two schools that got that inaugural award, Leeds School of Medicine in United Kingdom and SIU School of Medicine in the USA. We got the award because we had lifetime achievement awards in student assessment, social accountability, student engagement in the curriculum, medical simulation, and curricular innovation and excellence. So that pretty much defines, what the School of Medicine has been doing these days. So, a lot of great stuff and a lot of great collaboration that we can do. So we'll just get on with the program tonight. So our speaker tonight is Dr. Vidya Sundareshan. She is, an infectious disease physician. Actually, she is the department head of our infectious disease division and also has a degree in public health. She has brought the School of Medicine through the pandemic. She has collaborated with the Sangamon County Health Department and the state of Illinois to develop excellent new programs. And she's just been a great advisor to me as the dean as I've made major decisions for the pandemic. So Vidya, Dr. Sundareshan is going to speak on post-pandemic and public health matters. And so we're all very interested in the new world and how we're going to act and live as we come through this pandemic. And hopefully we're kind of on the wind down phase right now, but we'll see. We're going to have a good talk tonight. So Dr. Sundareshan, the floor is yours.
Thank you, Dr. Cruz. And thank you so much for having me. I'm really honored to come and speak here today. So I am going to talk a little bit about the emergency phase of the pandemic and then start out with a personal story. So I think the next few slides really talk about the emergency phase and my story with that. March 3rd, I was getting back from a big fat Indian wedding. My brother got married in Austin, and I was coming back from there. It was the first time a lot of our family members got together, and this was in Austin. And as soon as I landed there, they said the city's closed. We have somebody who's been diagnosed with COVID, and that lady was actually in the mall, and we have to close the city down. And we weren't sure whether we were going to have the wedding or not. The wedding happened. A lot of our relatives came, and I remember telling my cousins that, oh, it's just a common cold. It's okay. You'll be fine. Just come. So this was 2nd of March, 2020. So I come back March 6th from the wedding, and right after that, we have to make a decision on what to do with the schools. Are we going to close down? What exactly needs to be done? And you can see my face there. I had no idea what to say. Well, I think at that point, I was scrambling, talking to a lot of the infectious diseases doctors. Seattle, in fact, had already seen a lot of cases. They had an outbreak in a nursing home, and they were just beginning to close their schools. And one of the doctors there in Seattle, who was a public health specialist as well, was on one of the committees. So I reached out and I said, what do we do? And right as I was doing that, CDC came with some guidelines. Okay, CDC gives blanket guidelines. Now, do we actually apply that in Illinois? Are we okay to do that? And what do we do in Sangamon County? Is that really going to apply? So from CDC to the state level to Sangamon County, decisions had to be made, and it was very easy to just align everything. So we went ahead and made a decision at that point. 13th March, schools were announced to be closed, and we didn't know how long this is going to be closed and where to go from there. We had our first case of COVID around the same time, and this was the first time when nurses would comment and everybody would comment that all the organizations came together, power of collaboration. All the organizations were actually there to comment on what we are going to do, what are the issues we may face with a PPE shortage or mitigation. What are we going to do? We're going to do this together. So resources were pooled, ideas were pooled, everything was done as a group. And that was really a great thing to happen in the community. So the emergency phase, forging partnerships. So I'm going to be using a lot of quotes here from a book that Dr. Fauci recently wrote about forward and being prepared, just being prepared in all eventualities. So we live in a global community. That means interconnectivity. That means communication. That means transparency. And all these were actually present for all the organizations, from communications to education to aligning guidelines. We were doing that together. So it was very nice at that phase to come together and do something for the community as a whole. Our cases started to go up. Around 15th of April, we were expecting a surge. So we were seeing that in New York. We didn't know what the surge would look like in the Midwest. And I actually learned a lot from Dr. Cruz's publications that he would actually put out every Thursday. He published data and his own commentary, and it's very, very educational for all of us. Talked about how things happened in Europe. A month later would happen in the US on the East Coast. 2 weeks later, you would see that happen in the Midwest. So, it was really nice to see the curve and, anticipate what's going to happen. So we expected our surge that was calculated by modeling around 15th of April. And what do? How much do you really prepare? So this was a picture from our first grand rounds. We gave grand rounds in MCLI. This is Memorial's Innovation Building, where we usually have our grand rounds. And for the first time, we gave that to an empty hall, nobody. We were posing with our arms apart and 6 feet of distance, and really initiating the COVID guidelines at that time. That was the first time Grand Rounds was actually done this way. We had to plan. When we said no audience, everybody was, how are you going to do this? But, well, that's become the new way of life now. So contingency. Next came contingency. You have to plan for the hospitals in terms of what are you going to do if our ICUs get full? We weren't going to have ophthalmologists take care of our ICU patients. That's one thing for sure. But we had a plan. Residents, how are we going to plug them in? How are we going to plug in medical students? So planning for March, April, May, June, July, August, I've just kind of used that timeline there. But biggest issues in March were policies. What do we do at a local level? Testing, PPE, patient care, mitigation, what kind of policies do you really need to have? In April, planning for the surge, making sure there are enough people to take care of patients in the hospital. And again, PPE for them was a big thing. With treatments, what are the new treatments? This was the time when we started to get plasma. And now plasma is not even part of the plan for treatment. But plasma from people who have had COVID was big during treatment at that time. We didn't have any medications. Then remdesivir was introduced and other medications when they were introduced, that was later on. And then testing. What are we going to do about testing? And SIU actually, Lori helped us out a lot with that, established a lot of community sites. There were people who were trained on the spot. And then I'll show you a picture there. In fact, just how the community came together. There are people from, the School of Medicine who were just coming to take pictures or just coming to help out. They were registering people. Some of the nurses called their friends, and just having people as a community effort to get that testing done. There were cars and cars just with a long line, and we would get through them. So those kind of issues were what we were facing in April. In May, technology, hotspotting, modeling, all this became really important. And we would see areas where there was disparity in terms of treatment, in terms of testing, in terms of diagnosis. So those kind of issues began to surface in May. In June, again, testing. What are you going to do with contact tracing? We needed to build a whole team to contact trace people that were exposed. And all those issues in June started to become more important. Optics, again, in June, July. July, we had a pretty reasonably sized uptick there. So testing again at that point. Schools were closed for quite some time. What are you going to do? Schools will reopen pretty soon. How is it going to be? So those kind of decisions were needed to be made. And then masking. It was messaging about masking. Vaccine information at that time just started to surface. So, how are we going to message about all these things? So those kind of conversations were always happening with the groups. So PPE, lack of PPE, remdesivir, antiviral, and then the plasma that I was talking about. This is a picture of New York where some of our nurses who volunteered there. Even now, the kind of trauma that they have gone through with seeing so much death and dying and pain, that's something that we never want to go through again. And then again, testing. These were sites where we had makeshift tents with a lot of equipment, a lot of things that people could actually with COVID come and go to these. Instead of ERs, you can't send them to ERs. So makeshift clinics, all those were top of the agenda there in May and July. School guidances. I've just included a copy of how we would go through those. Red, yellow, and green, just the school guidance. And at midnight, we would sit and edit this with a group of people and a glass of wine. So, so, I think they did a pretty good job despite the wine. That was another a COVID risk infographic. Messaging was so important. So, that's an example of one of the infographic that I was part of with the Infectious Diseases Society of America. So here, core public health service is doing something that's beyond your own self, beyond your own potential, without any selfish motivations there. Dr. Fauci on Live to Serve. That was one of his, that's again a quotation from the book. Parking lots were empty, so you could get to park close to the door. So that was a perk there. This is a picture from the library. There's hardly any people there, and we were greeted by the skeleton there with a mask. Keep your mask on, a good reminder there. This is what it looked like. So this was at the county board meeting where, persisting to persevere and prevail. The more energy you put in things, the more you're going to accomplish, and it's almost infinite. So this is a picture from one of those board meetings. On the corner there is hotspotting. That was done by the county and identifying those areas, those dots where the number of cases were high. It helped us identify, okay, is there a transportation problem? Why exactly are these zip codes with higher cases? What's going on? And we were able to find a lot of things with that information. Somebody was coughing in this room, so I was banished to the chair's office there. So I took a selfie there, took that chance to get a selfie. This is from nursing home visits. We had our first nursing home where the villas where we had an outbreak. Personally went and made a trip there, saw how nursing homes were handling that, the public health team. And it was really an experience to see people reusing their masks. They would have brown bags, reuse masks, put those and hang those. And some of the masks were moist. A lot of people were getting sick, taking care of these patients. So it was a task to try to come up with guidelines to control outbreaks there. That was a really nice stand outside one of the nursing homes where the families could be on either side and actually talk to their loved ones. So I took a picture of that. And then, every time we would drive out, I just did stop and enjoy the greenery and the beauty there. Here in the bottom is a device where patients that had COVID, they're elderly patients, and they're isolated when they have COVID. How are you going to manage them? So this device actually was placed in their rooms to monitor what's going on. Not the best, but there were some things that the nursing homes were doing to keep their employees safe as well. All right. Always try to look for positive in people. And it's one of the guiding principles of empathy. And leadership takes many forms, including leadership of example. And we have a great leader actually here in our room here. So I want to just say that I feel so fortunate for the support we got from SIU. Because this is, in fact, one time where, public health infrastructure was poor, very poor. We needed a statistician to help with the data. Dr. Cruz immediately said, okay, why don't we provide that from the school? We needed testing. Why don't we provide that from the school? We need PPE. Okay, the school can provide that. Everything that we asked for, everything that we needed, leadership like this was able to get us. So I think that's huge. That's huge in how our community actually responded and did during the pandemic. And I put pictures of people who were in my circle there, who I look up to a lot. Right there is Dr. Vidya Prakash. She is the CMO, and we are popularly known as the COVIDs. She's Vidya and I'm Vidya as well. So, so we were the COVID's 2020 versus COVID's 2019. And then and the picture in the bottom is Dr. Flack, who's the department chair. ACP, American College of Physicians, their leaders had a lot of guidelines and a lot of material that we could share too. And then here's Dr. Hingle, one of my mentors. So really our true job, our true work is not our job. It is what we do, not what we were created to do. Our true work is to look after each other, to protect each other, and to be of benefit to one another. That's from Bill Gates. So I think we were definitely role modeling that with the leadership at SIU. So what did education look like for us? We had to transition everything to virtual. That's our rounds. Our pharmacist and one of our students there. That's just a screenshot of my computer. And here's Dr. Rabinovich. I don't know if you recognize him, but he's one of the oldest members of infectious diseases, Department of Medicine, 95 plus, and he still attends our conferences. So he's amazing, and still contributes. What he says, I think we all learn from even now. So that's a picture of him, and he started to navigate the computer. Now he knows how to unmute himself, which is great. And yeah, he's in Carbondale. And so we didn't have graduation. That's all our students there, and how we recognize them. It was their pictures in the newspaper, so no graduation. And then meetings, we actually interviewed a new faculty who's now a part of our faculty at SIU. She visited, but none of us could be in the room to talk to her. This was all done virtually, and we were joining meetings from our phone, and so just a lot of change in how things were done. Okay, now for the scientific part here. Milestones. I borrowed this from MedTwitter, Dr. Eric Topol, put this together, and just tells us how fast the vaccines were developed. Science being unfolded on a global scale. December 1st, when we first got wind of this virus and the structure of it, to December 11th, 2011, you already had a phase 1 vaccination for healthcare professionals. How cool is that? So, and there was no cutting corners. It was just red tapeism, bureaucracy, which was eliminated, but none of the scientific steps were shortcut there. So that's a nice slide of the events. And we still were in the pursuit of truth. If you really want to be effective, you got to know that you're going to tell the truth. Even though it may be something that sometimes people don't want to hear, and the best route to truth is science, philosophy, art, all of the above. Anthony Fauci. So yes, we had our march for Black Lives Matter, and everything done in a safe way with masks and social distancing. So, and this was important. This was important to continue to do. All right. Pursuit of passion. I am a musician, and I also am trained in Indian classical dance. I didn't dance during the pandemic, but yes, I created a video for the Indian government with my children, composed a song, and that was something that was an outlet for me. My husband's in the ICU as a critical care specialist. So we had a picture from the wedding, and then that's how we looked for most part. And then, on top is the testing site. So pursue your passion, even in the pandemic. It's very important. Okay. So this is something that my daughter gave me. Virus Fighter, we're superhero fans. So she drew that for me, and I just put this there because this is really the impression that people had of healthcare workers. It's sad now with a lot of violence against healthcare workers and a lot of issues with post-pandemic. But that was something that our community was big on, appreciating what we were doing. That's the picture I was telling you about. Anybody who actually came to even take a picture or something like that, we got them to work. Put those labels on the bottles, and we were able to get everyone to help. You can probably get a glimpse of the cars that were there, and the cars, the testing was done very, very quickly. So together we can do great things. All right. And spirituality, always important. This was another thing that we focused on. I was talking to my mentors a lot, talking to coaches, and sorry, that picture kind of is blurry, but this is our division of infectious diseases pre-pandemic, a picture from our group, and still strong, going strong, virtual, but still going strong. But a lot of the times in that 1.5 years, that's how most of us felt, just tired. But really great messages coming from everyone, our circle of friends, and the support system we have at SIU was just unbelievable. All right, end of the emergency phase, end of the picture. So I'm going to go to the scientific part now. Talk a little bit about post-acute sequelae of COVID, vaccines, therapeutics. That's a lot, but I'm going to cover that pretty fast. So long COVID is something that we are seeing after COVID, about 3 months or so after people have COVID. They can have symptoms which are anything. There are a list of 300 symptoms that CDC recognized. Then they kind of shortlisted that to about 26 main symptoms. And we see a lot of patients with these conditions, anywhere from neurologic, kidney failures, musculoskeletal, just weakness, brain fog, cardiovascular, just tachycardia, respiratory conditions, just shortness of breath. Got marathon runners not able to do anything now. And it's 1.5 years, they're just unable to run. They're unable to exercise. So, and then blood clots. We know for sure people who've had COVID have a 2.5 times higher risk of having any sort of blood clots. I got a call yesterday actually from someone saying, are you seeing a lot of blood clots in young people? In young people with COVID, with this particular strain, is it higher? I haven't seen anything like that, but the data is there with regards to blood clots, 2.5 times higher. So this is really how the post-viral phase goes. You have the viral phase, then you have a chemical storm. Right after viruses, any infection, body has this chemical storm. Then you have the clotting phase, and then the late hyperinflammatory phase. So that's where you basically see a lot of that post-COVID reconditioning. A lot of the damage is from the reconditioning too. And these are the statistics. 69,000 patients with COVID in Sangamon County. About 30% of them end up having some kind of post-COVID symptoms. So about 2,100 patients. 5 to 10% with severe symptoms, about 4,000 to 7,000 patients. 1% to 2% seek medical attention. So that's the number of patients in our small community with post-COVID symptoms, and that's what we needed to kind of have an infrastructure and help build. So again, every organ can be affected. And this just kind of gives you a timeline. Week 2 to week 4 would be the acute COVID phase, and then the post-acute phase, 12 weeks and later, you see that post-acute phase. So it's from direct viral toxicity or immune reactions from the chemical, or people that are admitted to the ICU and are there for a very long time, they can have a post-critical care sequelae or side effects from that as well. So those are the main 3 things in the pathogenesis there. And again, I've included all the organs and what you can typically see in this slide. I'm just going to go through it fast. Lungs with just fibrotic, it's just very thick, so ARDS there. You can have rashes, you can have brain fog, people have strokes, kidney functions are off. People can develop diabetes, which is new. So lots of things, every organ system there has been described. And again, a special mention to coagulopathy. which is just hyperinflammatory and hypercoagulable states that you see, with a lot of damage to the vessels, blood vessels, endothelial injury and complement activation, all this being the reason why we see this. And presenting symptoms, you know what, the loss of taste and smell, people can have that for up to 2 years. Yeah, so up to 2 years is now that, and now, in fact, some of the recent data says it can be permanent, unfortunately, with this. So, you know, I've had patients with this. One of them, a farmer, comes and tells me everything tastes like cardboard. I can't drink Coke. That was his biggest concern. So, it's been about 6 months. Yeah, expected that to get better, but he's starting to taste a little bit. But we have a support group. There are lots of patients that have these symptoms. One of them said, I want to get a ganglion block. And with the ganglion block, I've heard that the anosmia or the sense of smell improves. We looked into that, but it was not worth it at that point to get the ganglion block just for that sense of taste and smell. We wanted to wait, and actually that patient is improving. But it can be a really bad problem. Can you imagine everything tasting like cardboard? That's bad, and not being able to smell anything. And worse, if your smell is, in fact, the sense of smell is altered, that's even worse. So, this was, you have hematology, cardiovascular, renal, primary care, neuropsychiatry, so many different groups coming together to manage these patients with post-COVID. So that's what we did. Competitive athletes, actually, that group, their activity you have to really pay attention to, just graded activity levels post-COVID. They needed echocardiograms to even get back to their sports. So that group we were really paying attention to as well. And then a lot of people that had brain fog. That's a common complaint there too. Just a lot of diffuse muscle pain, brain fog, difficulty concentrating. And there's not much we can do in terms of medications there. So we have a support group, and I'll talk a little bit about that. We put this together. We envisioned this, put this together with the support of our leadership again. We were able to go live November 1st, 2021. Multidisciplinary, pulmonary, physical medicine, rehab medicine, cardiology, rheumatology, psychiatry, general internal medicine, ID kind of came together. That's our big team. Operations helped, risk management helped, FQHC referral base helped, marketing, IT, billing, all kind of support for this clinic. I'm really grateful that we were able to have that. And then we got a multidisciplinary COVID board, so almost like a tumor board. We would meet once a week and talk about the patients. So brainstormed. We had bundles and sets which we can quickly do documentation on. We had nurse practitioners who would help do the intake and present these patients. And we roped in our ID fellows as well as medical students. So medical students actually helped us out with a lot of our efforts. Our infectious diseases fellows, we gave them credit for the work they did, discounted as their QI research project. So everybody was involved. And this is what the document looks like, which was placed in all the clinics for messaging about the post-COVID recovery clinic. And it was challenging to get everybody together, but we got through about 5 to 10 patients per week. And it was an educational conference. We shared a lot of literature. And then every specialty had a point person. So if I had any cardiology issues, I know which point person to go to. They were already in that group. In fact, we had a couple of referrals from Carbondale. We were able to do that via telemedicine, and then the cardiologist was able to see patients right away, or pulmonary was able to see patients right away. So telemedicine definitely was helpful in that phase. We had a lot of patients with anxiety. That's still something that we're looking to have a good pipeline for referral to psychiatry. Psychiatry is part of our post-COVID team as well. And then the support groups. This is something I'm really proud of. Our medical students have been involved with this, and they've done a really nice job. These are supposed to be patient-led. We have about 12 to 15 patients that participate in this, and we learn from them. I was just talking to someone about a histamine diet. Never heard of that. But one of the patients said that helped him gain energy. He was asking about making yogurt at home. It's a very common practice in India to make yogurt at home. So I was able to share some tips, and now that's become like a standard recipe for the group. So it's nice to learn from each other. And then, we have an expert come and talk. So in January, we're going to have somebody from YMCA come and talk about just strength training and the importance of strength training in these patients. So I hope you can join us actually in January for this as well. All right, so far 250 patients taken care of, males, females, equal ratio. That's what the breakdown kind of looks like. 20 to 70s age group, and a lot of them were unvaccinated in this group as well. Okay, future directions, funding, opportunity, telehealth, just a lot of progress there. Some patients maintaining their journal, sleep journal, sleep hygiene. These are some of the things we do routinely for the patients. And their clinical trials, still a lot of things that are coming out with. This is a big group of patients that NIH is invested in and trying to understand what's going on as well. Study that just came out actually yesterday. And a lot of them have not fully recovered, so that's not very good news. But this is by far one of the largest studies in post-COVID from Scotland. So we have to see how what it looks like in different cohorts. But many of them have persisting symptoms after 18 months as well. All right, a little bit about vaccine and therapeutics. So I'm going to talk about remdesivir. This is a drug here, nirmatrelvir and ritonavir. So really useful for COVID. Decreases the viral load. 5 days, that's all you need to take. And it's not everybody can take it. People over 65 should take it if they get sick. That's one place where we can definitely do better. So this is the line of treatment now for outpatient Paxlovid. That's the name of the drug. It's a protease inhibitor and really drastically reduces viral load. 90% effective in keeping people out of the hospital, keeping people from dying. So very, very useful there. Remdesivir and monoclonal antibody, that's another thing that's very useful as well for treatment. We do this at SIU as well. This is a test to treat protocol with state of Illinois. Now they're trying to get even pharmacies to be able to prescribe this drug, remdesivir. Somebody gets diagnosed at home, you don't need a doctor's prescription. Pharmacies are able to get that prescription. They're able to check drug-drug interactions, which is the most important thing there, and are able to give that medication. And we're able to actually activate that through an SIU hotline. So that's a new thing. And we're trying to expand the service to central and southern Illinois. They're actually asking us to do some northern Illinois too. So we may have more outreach there. So that's about Paxlovid. No treatment versus treatment. Just want to show you how people kind of respond without treatment. The hospitalization there is so much higher as compared to with treatment. Very effective drug. And another monoclonal antibody, long-acting monoclonal antibody, this is also available, should be used in people who qualify immunocompromised patients. So people older than 65, people immunocompromised, people with risk factors, we have to target those people. So these are some of our latest numbers. I'm not going to belabor this. We see it every day. Death rate is still a little high, although there's a sustained decline. Last 1 month, our numbers of COVID have been down, which is a great thing. So are we getting to endemic? That would be something to watch. Sangamon County is low. We're in the low range now, so that's great. This is what our metrics look like, from 3,627 down to 213 cases a week. So that's great progress. I just wanted to show you, people ask, what are the risk factors for dying? They've studied many things. If people have a lot of medical conditions, that obesity was another thing that was identified. But despite all the other risk factors, being unvaccinated was the biggest risk factor for death, biggest risk factor for hospitalization. So these slides actually just go to prove advanced age, and you look at all the other risk factors, they're unvaccinated, that is the risk of dying and getting hospitalized. Excess mortality, different countries in comparison, US actually did very poorly because our vaccinations and booster rates are 40%. Japan, they're about 90%. So that's the difference between Japan right at the bottom, US, our excess deaths per capita are much higher as compared to Japan. It's a really nice comparison here of getting one dose fully vaccinated with boosters. See the difference between Japan and US. So definitely vaccination is very, very useful. More slides with comparison. I don't have to say anything. The gap speaks for itself. This is what the population curve looks like. In Japan, about 24.6% over the age of 65. That's the curve, 15.3% in the US. Despite their dense population, they actually did so much better. The curves look markedly different, so you can argue, but that's why the results look different with vaccination too. But vaccination in itself is an independent factor in the differences. Another source, same data. So fall COVID booster campaigns are definitely very, very helpful. Same source from Infectious Diseases Society of America. Those curves between the different vaccine groups you can see are definitely very, very impressive there. Children's vaccines, again, risk of symptomatic COVID in all age groups, 6 months to 2 years, 2 to 4, 5 to 11, 12 to 18, you can see that there was a significant reduction. Intranasal vaccine, there was data now that the antibody response was not that great, but we were hoping intranasal vaccines would be great. But the data now is showing that the antibody response, just one study, so we're going to get some more. Florida Surgeon General actually said, be careful, men between 18 and 39, be careful because of pericarditis and risk of that. Well, that was based on some unauthorized publications. This is what the real study is, and a lot of the experts actually have slammed the Florida General's warning on coronavirus vaccines for 18 to 39 based on the pericarditis. That data actually does not really exist based on which that decision was made. All right. Another important thing, Novavax, different type of vaccine. We're also looking at Covaxin, which is like a whole virus vaccine, different from mRNA. Response is better. So you'll see that with endemicity, that's one thing that we're kind of looking at as well. Don't forget to take your flu shots. Very, very important. This year, COVID winter wave, are we going to have relatively quiet COVID winter wave, but influenza is going to roar, according to some of the literature. So we will see some descendants of the circulating Omicron, but I think we'll still do well with the vaccines, and the boosters are really pretty effective against these as well. And that's what the data is showing. Length of isolation, just one, reinfections with the newer Omicron, it escapes immunity. Immune escape is much higher. So reinfections are seen a lot more. And this particular article tells you that even after that 5 days of being isolated, there's still viral shedding. So antigen tests are becoming very popular. And they, negative antigen tests, CDC modified their guidance recently based on that. All right. Social determinants of health. Just want to tell you, the more layers we have here in terms of, masking, other things that we have between personal responsibilities and shared and personal responsibilities, we're adding more layers to that Swiss cheese, so less chance of infection. All right, and COVID shined a spotlight on just political determinants and social determinants of health. I'm not going to go into the details, but If the health of a country is significantly lacking, leads to economic instability, political instability, leads to real problems. Public health permeates almost every aspect of our lives, both domestically and internationally. So we can avert a crisis there. And equity is something that we definitely have to be mindful about. All right. We are in a one world, one planetary world system now. And that's what this slide shows 26 animal reservoirs for COVID. The one world model is now being envisioned for COVID pandemic. And this is different from smallpox. This is different from some of the other viruses. So that's why we're not able to completely eliminate it or eradicate it. We will have to control it. So this is a slide that just talks about how we are envisioning this with the animal reservoirs as well. Just to tell you, this is how complicated COVID is. This is the biopathogenesis with the different proteins. It's just pretty complicated. That's how COVID is as compared to smallpox. Last few slides. Endemicity, just want to focus on this. So COVID can be controlled, cannot be eradicated. Herd immunity is out the window now. That concept doesn't exist with COVID. Because the variant transmissibility is so high, it doesn't really, it's not indicative of anything that we're looking for. Control. So that's a reduction of disease incidence to acceptable levels. Vaccination and therapeutics are key for that. So diseases like pertussis, diseases like smallpox, we were able to do that. Actually, pertussis, smallpox is eradicated, pertussis there. So no animal reservoir for the, and clear pathogenic features, short period of infectiousness, immunity for life, high effective vaccines. These are some of the features of viruses which will make it easy to eradicate or eliminate. None of these apply to COVID. None of these apply to COVID. So it's hard. So we cannot eradicate it, we cannot eliminate it, we cannot make it extinct like the dinosaurs, but we can definitely control it. All right. What does endemicity look like? This is what they did in UK. No mask mandates, no vaccine passports, self-isolation if sick. They don't even give you how many days. Self-isolation, no asymptomatic testing, test if sick and treat when needed. Normal school, but one-way masking for people that are immunocompromised, people that need it, one-way masking. Ventilation, key. That's something we all need to think about and plan in future buildings. Very, very important for respiratory illnesses. Mask recommendations moving forward on certain types of masks which are helpful. KN95, and N95, those kind of masks. And wastewater surveillance is becoming very popular for us to understand that. And this was from the president's plan, pretty similar to what UK was proposing as well. And rational roadmaps from some experts. Stop asymptomatic testing, look at wastewater surveillance, and stop quarantines, but self-isolation when sick. So these are all just futuristic views of how we can look at COVID. I'm just going to point out Covaxin use. That's the whole virus vaccine. And they definitely give a better response with the vaccine. So that's another thing that they're looking at. And rational approach to boosters. WHO said, base scenario, vaccinate vulnerable groups only in winters. Best case, you have a less virulent circulating strain, most will not need reboosting. Worst case, you have a very, very virulent strain circulating, that's when you're going to boost everyone. So there are some guidelines from WHO as well. And while we deal with COVID, there was another infection, monkeypox, which thankfully has gone down because of the vaccination efforts that still need to continue. But CDC has actually done a good job in terms of getting the vaccines and treatments to people that need it. And polio, you must have read about this, that's returned as well. Detected in wastewater in New York, and again, related a lot to the vaccination there. One last caveat there, what can we do? The trust in public health is so low. So we really need to make sure we have a harms reduction approach, and then trust in providers is still pretty high there. All right, and these are all the lessons that Dr. Fauci said. Above all, empathize, honor your community, pursue your passion, expect the unexpected, persist, persevere, prevail, live to serve, lead by example, be a lifelong learner, forge partnerships, something like what we're beginning to do here, and revere the truth. So these were from Dr. Fauci's lessons from the pandemic and way forward. A life well lived is to have made a contribution to society, leaving what you've touched better than before you had anything to do with it. So I'm ending with Dr. Fauci's quote, and I'll be happy to take questions. Thank you.
So, let me just say to our audience that's watching this, if you have questions, you can type them into your computer and we'll answer them here. But if we'll give them some time to think about that because I have 100 questions that I would like to ask. So, but I'll open up to any of you. Do you have any questions before I jump into my 100?
And I invite comments too, your experiences, and yeah, please.
So what was the time frame again from the point that someone had COVID until they could have long COVID, so to speak?
Typically 3 months in data. Yeah. So the acute phase lasts for about a month, and then between that 1 month and 3 months, that still kind of classifies as long COVID. By definition, anything after 6 weeks, we would consider long COVID.
So some of the symptoms that you showed on a couple of your slides, do we actually have people now looking into specific symptoms from COVID that you said could last anywhere from 6 weeks to 6 months or whatever? Are they focusing on trying to figure out the relationship and if there's a cure for some of those or not?
Yeah, so NIH is definitely invested in this. A lot of universities that have large post-COVID clinics have data. In fact, even with our post-COVID clinic, one of the pillars is to have data which we can use to contribute nationally. Every area epidemiologically is different too, so we will do our share in bringing forth our data that we collect as well. So yes, that data is being collected. NIH is giving out a lot of grants. I actually listed a slide with the clinical trials that are going on in this as well. And Dr. Ashish Jha makes a mention of this every time when they talk about post-COVID.
So because of one of your slides early, you were talking about the timeline, essentially from the beginning of the vaccinations to where we actually were shots in arms. These other symptoms that have resulted from people with COVID, would we fast track things like that if there were antidotes or treatments to cure those? Could we move that quickly as we did with the vaccine? There's a couple, but it's not looking very promising in terms of the treatment right now. Those are ongoing trials and studies. I think the biggest thing right now is vaccination as treatment for post-COVID. So if someone is not vaccinated, the first recommendation is to start off with vaccination. And then these are very symptom specific. So somebody has anxiety, then you get medications for anxiety. If someone has weakness, muscle weakness, and shortness of breath, you want to rule out any infection, any lung condition which could improve with rehab. So rehab is very useful. It's a multidisciplinary approach. Many people have symptoms which kind of cross over from one specialty to another. And that's why we envision this as a multidisciplinary group. Yes.
So many people were hesitant to get the vaccine. Some said it was too fast. Others were mRNA. I don't want my DNA messed up. Apparently the way of the future is mRNA vaccines. I mean, is this true? And if so, how do we get over this hurdle of I'm not going to do this because I want to have kids 2 years from now?
Absolutely. And that, that's a conversation which I think pretty much every medical society is having, these conversations. And combating misinformation, ACP, American College of Physicians, has a YouTube channel just dedicated to that. Yesterday, there was a big discussion with the infectious diseases group. Same thing, misinformation. How are we going to make sure that the real correct information is out there? But with your question about mRNA, it's a great vaccine, but the problem with mRNA vaccine is it's just a small part which actually creates, it gives our body to form the antibodies based on the message that the mRNA has. And that can have a lot of small little quirks there. mRNA vaccines, 6 months, we know for sure the immunity lasts. Can it last longer? Maybe later on, with the different types of mRNA vaccines that they're making, bivalent, etc. But I want to take you to the last slide that I had. This was, in fact, one of the discussions from infectious diseases expert groups that talks about Novavax and Covaxin use. So the whole vaccine, the whole virus vaccines, the immunity for that is more long-lasting. So that's another thing that they're looking at, and they really are advocating. Novavax is now approved here in the US, but Covax, they're really advocating to get that approved as well. So there'll be options.
Is it fair to say, based on what you know today, that if we would never go back to where we were back in December of 2020?
There's a lot of information that we have, but it's surprising how quickly we forget it. And we saw that with monkeypox. And that's one criticism we've heard from a lot of the scientific community saying, we know it, we know what works, then why are we not doing it quicker? So I think that's really underscores the importance of having a good public health infrastructure, a good infrastructure in the community for identifying things like this. Right? Thank you so very much for this opportunity.